Dear colleagues, this presentation is prepared for clinical key for electrical stimulation in physiotherapy and rehabilitation project. The project partners are Pamukkale University, University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Şilay State University of Applied Science, Burdur Mehmet Akif Ersoy University, and National Physiotherapy Associations. I am Özlem Yürük from Başkent University. The subject is electrical stimulation for axonotmesis. Axonotmesis is a term that describes the range of peripheral nerve injuries that are more severe than neuropraxia and less severe than the transection of the nerve as observed in neurotmesis. This injury can be caused by blunt injury, fractures, dislocations, contusions, or stretch or crash injuries. Axonotmesis was classified into 3 stages according to Sunderland. Axon loss is seen in grade 2 lesions. However, endoneurium is intact and recovery is slower in grade 2 lesions. Injuries of the grade 2 and 5 are characterized by additional loss of adjacent connective tissue layers from inner to outermost. The damage of the endoneurium in grade 3 injury disrupts the scaffold by which axons elongate for regeneration and causes neuroma formation. Variable outcomes are seen in grade 3 lesions. Neuroma formation and inhibited regeneration occur in grade 4 injuries. Recovery is poor due to peroneurial damage. However, the epineurium remains intact in grade 4 injury. Surgical repair is required for promoting regeneration in neuromas. And Wallerian degeneration. In axonotmesis, Wallerian degeneration occurs. Conduction block occurs immediately at the nerve injury site. The conduction distal to lesion disappears after 24 to 72 hours. During Wallerian degeneration, both injured ends retract with the proximal end, generally proceeding with degeneration to the closest node of Ranvier. Following the degeneration of the proximal stump, the Schwann cell converts to the degenerative phenotype and releases growth factors. An axonal growth cone begins to develop at the distal end of the proximal stump and is distally guided by actin and myosin. The optimal outcome is to contact the endoneurial conduit of the degenerative distal nerve segment and grow along the original trajectory to reinnervate the end organs. The growth of proximally damaged nerve is 2 to 3 millimeters in a day and 1 to 2 millimeters in a day for distal segments. And prognosis. The prognosis of axonotmesis relies on the underlying condition of the patient and nature of the injury. In best circumstances, the nerve can regenerate by axonal branching or through the expansion of the proximal segment of the damaged nerve. The regeneration becomes more likely with limited damage to axons and structural units of the neural trunk. Spontaneous regeneration is still possible with axonotmesis if the perineurium and epineurium provide any intact tubule. Distal lesions have a better prognosis. However, nerve regeneration doesn't equate to functional recovery. The function also depends on achieving the regenerated axons with the end organ. Muscle architecture and motor end plates are considered viable for up to 1 year post-injury. Prognostic factors for regain of function include a patient's baseline health, the mechanism of injury, the degree of injury, the length of the nerve gap, the type of the injury, the nerves involved, and the location of the injury along the nerve. Also, concomitant injuries, the timing to surgery, the type of surgery, and the patient's age are the other prognostic factors. Complete or partial loss of motor functions, loss of voluntary and reflex contraction of the muscle and progressive muscle atrophy, loss of sensory functions, muscle spindle atrophies, for example, Merkel atrophy. Some other receptors are lost, and autonomic loss, cortex plasticity occur after axonotmesis. Positive sharp waves are seen after 1 to 2 weeks, and fibrillation potentials are also seen after the 2 or 3 weeks after of axonotmesis in electromyographic evaluation. Before the clinical decision-making for the physiotherapy rehabilitation program and electrical stimulation, physical examination is essential. Physiotherapists perform electrodiagnostic tests and evaluate the muscle strength, range of motion, dermatome, anthropometric properties, posture, viscoelastic properties of the muscles, pain, and autonomic functions in patients with peripheral nerve injuries. The Faraday stability test should be routinely performed for the follow-up of the recovery process. Technology is also helpful in screening nerve injuries. Nerve conduction studies help to determine the location, severity, and progression of the nerve injury via motor and sensory conduction studies. However, electrodiagnostic studies may have normal results 2 or 3 days post-injury and may not reveal the full extent of the injury until 2 or 3 weeks post-injury. Additional diagnostic techniques such as ultrasound, magnetic resonance myelography, magnetic resonance neurography are needed for detailed assessment by clinicians. The effects of electrical stimulation on axonotmesis should be considered in terms of muscle and nerve recovery. Denervation atrophy is much more a complex condition than atrophy due to inactivity. Muscle plasticity is affected by many neural factors. The denervated muscle is neither voluntary nor reflexively active because it has atrophied and weakened. However, an appropriate electrical stimulation protocol can achieve contractions of the denervated muscle and prevent the decrement associated with denervation. In axonotmesis, the muscle is stimulated by sarcolemma, not by a neurolemma. This method is called electrical muscle stimulation. The electrical muscle stimulation prevents atrophy and keeps the muscle healthy as possible until reinnervation. In animal studies, the denervated muscles are stimulated with 600 contractions for 5 days a week after nerve injury and repair. The study showed that the stimulated muscles had a higher motor unit number. It was determined that muscle-derived neurotrophic factors, glial cell line-derived neurotrophic factors, and ribonucleic acid levels were high in stimulated muscles. The authors concluded that the electrical muscle stimulation of the denervated muscle could delay atrophy and promote reinnervation following the nerve damage. And the effects of electrical stimulation on nerve regeneration. Experimental studies have demonstrated that electrical stimulation to be a promising adjunctive therapy to enhance axonal regeneration and functional recovery following decompression and repair using grafts. Electrical stimulation acts through retrograde action potentials to increase cyclic adenosine monophosphate levels in soma, which drives the increased expression of brain-derived neurotrophic factor. Although the exact mechanism is not completely clear, electrical stimulation promotes axonal outgrowth and survival. The distance from the injury to the original target, slow regeneration of axons across the injury site, progressive decline in the regenerative capacity of axotomized neurons, failure of chronically deinnervated Schwann cells to transport the axonal regeneration, and muscle atrophy considered factors limited recovery. Extensive animal studies have reported the ability of brief intraoperative electrical stimulation to enhance functional regeneration after peripheral nerve injury. The 1 hour, 20 Hz electrical stimulation of the nerve after the nerve repair enhances the early expression of brain-derived neurotrophic factor and pro-regenerative associated genes and facilitates the sensory and motor axons grow faster across the suture side after transection of femoral nerve in rats. In a recent animal study, the effects of electrical stimulation on Wallerian degeneration were investigated. It used a rat model of sciatic nerve transection and provided electrical stimulation at the distal stump of the injured nerve. Electrical stimulation was applied immediately after nerve clipping, and 2-hook titanium wire electrodes were hooked tensionless on the distal end of the injured nerve. Biphasic current for 1 hour was used. The current intensity for each rat was adjusted to just above that required to induce the visible gastrocnemius muscle twitch. The results showed that electrical stimulation significantly promoted the degeneration and clearance of axons and the differentiation of Schwann cells. It upregulated the expression of brain-derived neurotrophic factors and nerve growth factor and increased the number of monocytes and macrophages. Evaluation of nerves bridged using silicone tubing after transection showed that electrical stimulation accelerated early axonal and vascular regeneration while delaying gastrocnemius muscle atrophy. In addition to recent studies supporting the encouraging the effects of electrical stimulation on nerve regeneration, some studies showed that the increased neural activity on sprouting remains unclear and controversial. In an experimental study, Tom et al. Used 20 Hz frequency electrical stimulation for 8 hours daily on tibialis anterior, medial gastrocnemius, plantaris, and soleus muscles. The neural activity reduced motor unit enlargement. The authors indicated that increased neuromuscular activity was not recommended for rehabilitation immediately after motor neuron injury or early stages of the motor neuron disease. Another researcher investigated the effects of electrical stimulation on neuromuscular recovery after nerve crush injury in rats. The authors showed that electrical stimulation impaired neuromuscular recovery at 14 days post-denervation. Muscle hypoexstability was accentuated by electrical stimulation at 6 and 14 days post-denervation. Although electrical stimulation reduced the accumulation of some proteins, it increased muscle atrophy. And and here is the advantages and disadvantages of electrical stimulation on reinnervation. The advantages of electrical stimulation are it reduces venous stasis and edema, increases muscle-derived neurotrophic factors, delays muscle atrophy and fibrosis, keeps the muscle active while waiting for regeneration, maintains the joint range of motion, enhances the sensory inputs, and maintains the relationship between the cortex and peripheral organs, and reduces the scar formation. And here is the disadvantages of the electrical stimulation. It maybe cause trauma to the innervated muscles. Also decreases production of neural cell adhesive molecules and acetylcholine sensitivity. Delays or inhibits collateral sprouting and reinnervation. Mimics the voluntary contraction, however, not the same as the physiologic mechanism of exercise, and no added benefit for trophic condition. The number of contractions per day is insufficient, and only superficial fibers are stimulated by electrical stimulation. High current intensity is needed to stimulate deep fibers. Two electrical stimulation techniques are used for axonotmesis: electrical muscle stimulation or intraoperative brief electrical stimulation on the injured site. Intraoperative brief electrical stimulation is a recent technique that has been shown to be effective in studies. Biphasic current with 20 Hz and 100 microseconds for 1 hour with implanted electrodes is used. Although the technique seems effective for regeneration, it is not practical for physiotherapists because electrical stimulation is used only after nerve repair and is an invasive technique. Here is the electrical muscle stimulation technique. As mentioned before, if the muscle is deinnervated, it is stimulated via sarcolemma. This is called electrical muscle stimulation. The electrical muscle stimulation is a traditional technique for peripheral nerve injuries. It can be used for completely and partially deinnervated muscles. But because of the physiological changes of completely deinnervated muscles, only modified galvanic current can elicit a contraction response. The pulse duration should be above 100 microseconds, and the pulse interval should be 2 times of pulse duration. If the reinnervation begins, the muscle can respond to Faradic current. The Faradic stability test should be routinely performed for reinnervation. The Faradic current is an alternating biphasic current with a short pulse duration. Therefore, it cannot be effective in complete deinnervation. If the muscle doesn't give a contraction to response for a Faradic stability test, the galvanic current should be used for electrical stimulation. In partial deinnervation, the Faradic current can also be used. Alternating currents are comfortable for patients and can elicit the greater muscle torque. Tanaka et al. Suggested that electrical stimulation using alternating current has the potential to become effective therapeutic intervention to prevent deeper muscle atrophy. The frequency and pulse duration of the electrical muscle stimulation should be determined according to the fiber type distribution of the muscle. If it is a slow twitch muscle, a frequency below 40 Hz should be applied. If it is a fast-twitch muscle, 50 or 70 Hz should be chosen. The pulse duration of the Faraday current is 0.121 milliseconds. This value is equivalent to chronaxia. There are points to be considered in practice. Due to elongated sarcomere length of the denervated muscle, the length of the muscle should be shortened while performing electrical stimulation. In addition, the patient should monitor muscle contractions so that the stimulation of the somatosensory field is strengthened. Applications should not be too long due to the low oxidative energy mechanism and should be done 3 days a week for maximum 8 weeks. It is recommended that the current amplitude be as high as tolerable and capable of stimulating tetanic contraction of the target muscle. The atrophied and the innervated muscles are vulnerable to trauma. Excessive electrical stimulation can cause trauma, and also higher current amplitudes elicit strong and deep muscle contraction. However, higher amplitudes can also cause trauma. The long pulse duration and high current amplitude can be painful if the sensation is intact. However, the goal is to maximize the contraction response while minimizing pain. Physiotherapists should avoid fatigue when using electrical muscular stimulation. In order not to create oxidative stress in the muscle, the application should be stopped when the signs of fatigue are seen. The 2,000 muscle contractions per day are sufficient to prevent muscle fiber atrophy. The treatment sessions are planned 3 or 5 times a week for approximately 8 weeks. The electrical muscle stimulation should be started after nerve reinnervation begins and should be terminated when active movement begins. The electrode size and type depend on the size of the muscle to be stimulated and the intensity of contraction to be elicited. Small or pen electrodes can be used to localize stimulation to small muscles. Larger electrodes are needed to stimulate larger muscles and muscle groups. One electrode may be placed over the most excitable part of a muscle. The second electrode is placed at a convenient location near the muscle being treated. Electrical muscle stimulation should be performed carefully if there is a co-contraction. The antagonist should not be contract simultaneously. And the clinical evidence of electrical stimulation in axonotmesis. There are studies in cauda equina injury, nerve compression, and obstetric brachial palsy patients. Electrical muscle stimulation has been used for many years to excite paretic muscle groups of the extremity affected by obstetric brachial plexus palsy. One reported benefit of electrical stimulation is that the infant becomes more aware of the extremity affected by the palsy. Because electrical stimulation can activate muscle spindles and maintain sensory input. It also keeps the muscle active, waiting for regeneration, improves blood flow. However, some studies concluded that the increased neuromuscular activity should not be recommended immediately after motor neuron injury or in early stages of the motor neuron disease. The key is the time frame in which applied activity or stimulation. Certainly, electrical muscle stimulation should not be applied to muscles that are not demonstrated muscle motor function, nor should this technique to be utilized during initial and acute phase of the palsy. When muscles demonstrate reinnervation, there may be an indication for electrical stimulation. Although electrical stimulation applications are recommended for muscles with innervation in the treatment of brachial plexus palsy, the age at which application will be performed and method of application and the current parameters have not been clarified. More studies are needed in the pediatric population to clarify the application method and current parameters. El-Naggar evaluated the effects of electrical stimulation during weight-bearing exercises on shoulder function and bone mineral density in children with obstetric brachial plexus palsy, aged between 3 and 5 years. In the randomized control trial, 42 children with obstetric brachial plexus palsy were recruited. They were randomly assigned either to the control group, received an exercise program, or the study group, exercise program and electrical stimulation during weight bearing. One channel was used to stimulate shoulder flexion, elbow extension, and wrist and finger extension. And the other one electrode placed on the anterior fiber of the deltoideus muscle, and the other electrode was attached to the common extensor origin at the lateral epicondyle of the elbow. An alternating symmetrical biphasic current with 10 Hz was used. The tapping sensation was tolerated. The frequency was increased to 30 Hz to produce the muscle contraction. The intensity was increased gradually and very slowly according to the child's tolerance. The duty cycle was initially set for 10 seconds on and 20 seconds off, and the cycle was set at 15 seconds on and 15 seconds off when the previous setting was comfortable and showed no signs of fatigue. Electrical stimulation was applied for a total of 15 minutes. It was found that electrical stimulation during weight-bearing exercises is an effective and simple method to improve shoulder function and bone mineral density in children. And caudate cuna injury. In a study by Modlin et al., they evaluated the effects of electrical stimulation on the innervated muscle in spinal cord injured humans. In the clinical study, 27 individuals with caudate cuna lesions were included. After initial examinations, patients started their electrical stimulation treatment for quadriceps femoris muscle, gluteal muscle, and gastrocnemius muscles bilaterally. The electrical stimulation was applied by a specifically developed stimulator with large electrodes in sponge beds, which were placed over the muscles. After 4 to 6 months, when the skin had adapted to electrical stimulation, the electrodes on the thighs were applied directly to the skin with a gel. Patients were controlled every 4 and 8 weeks, and the stimulation protocol was adopted. They were found that increase in muscle mass and quality and the trophic situation of the denervated muscle limbs improved obviously in this study. And the other studies are about nerve compressions. Carpal tunnel syndrome is the most prevalent compression lesion and initially presents as recurrent nocturnal paresthesia and dysesthesia. The progression of the carpal tunnel syndrome may cause loss of sensation, and ultimately tenor motor function in moderate to severe cases. For a carpal tunnel syndrome patient with mild symptoms and no axonal loss, non-surgical treatment options are standard. In later stages, the syndrome symptoms of axonal loss are present, thus necessitating the surgical release of transverse carpal ligament. Carpal tunnel release surgery is known to be highly effective, but lack of symptom improvement and prolonged recovery may occur due to extensive axonal loss before treatment. Therapeutic strategies to accelerate or decrease or increase median nerve regeneration in chronic carpal tunnel syndrome would undoubtedly have profound implications. Some studies used electrical stimulation during surgical repair for one time and an external stimulator. The results showed that electrical stimulation applied to the injured peripheral nerves during surgical repair can enhance nerve recovery, both sensory and motor functions. However, it is not practical to use these techniques. Gordon et al. Investigated electrical stimulation as a surgical adjunct in a randomized controlled trial of patients who underwent carpal tunnel release surgery. Patients with chronic median compression neuropathy, evidenced by clinical signs of tenor muscle atrophy, and at least 50% axonal loss on motor unit number estimation were enrolled. Median nerve electrical stimulation was delivered with wire electrodes within 15 minutes of carpal tunnel release. Compared to the control subjects without significant increases until 12 months post-surgery, the 11 subjects who received median nerve electrical stimulation had significantly increased the motor number estimation by 6 to 8 months post-surgery and achieved a normal number estimation by 12 months post-surgery. The use of median nerve electrical stimulation enabled all motor neurons to regenerate the achieved tenor muscle reinnervation more rapidly following median nerve decompression. And conclusions. We can say that here in axonotmesis, two electrical stimulation techniques are used: electrical muscle stimulation and intraoperative brief electrical stimulation on the injured site. Clinical evidence suggests that 1 hour of 20 Hz electrical stimulation applied intraoperatively following repair can improve patients' recovery. Although the technique seems effective for regeneration, it is not practical for physiotherapists because electrical stimulation is used only after the nerve repair, and it's an invasive technique. The other technique is electrical muscle stimulation. There are experimental and clinical studies on electrical muscle stimulation in the literature. Although past studies have shown the harmful effects of electrical stimulation, recent studies have supported the electrical muscle stimulation. The electrical muscle stimulation should be started after nerve reinnervation begins and should be terminated when active movement begins. First of all, the alternating currents should be preferred. If no contraction response is obtained from the muscle, a modified galvanic current should be preferred. The patient's tolerance and the amount of treatment should also be considered. Further studies should be planned on axonotmesis to determine the optimal stimulation parameters of electrical stimulation. Shorter application times, more convenient devices, and other indications could be evaluated. Thus, continued research efforts are ongoing to provide the evidence to identify optimal electrical stimulation delivery paradigms. Additionally, novel biocompatible and bioresourceable devices with electrical stimulation capabilities may be available in the near future and provide new perspectives on the long-term application of electrical stimulation. Thank you for your attention.